Keynote? Okay. All right, I'll take this forward. For the final closing keynote address, I would now like to invite on stage Padma Shri Professor Dr. R.K. Grover. He is the Consultant Oncologist Advisor, Sri Hanuman Balaji Charitable Trust Institute and Founder Director of Delhi State Cancer Institute, East and West Delhi. Dr. Grover is known for his contribution in the field of medicine and has over 50 scientific papers to his credit as well. Mr. Grover, welcome. Thank you so much.
New shoes I got online.
It's called entering with style.
Yeah. Thank you so much. Thank you everyone for sitting till the fag end of the session. I'm so grateful to all of you. I'm so grateful to Republic channel, Republic Bharat. I think you are all probably Republic Bharat staff only, so you are bound to sit till the last. Doesn't matter. Thank you so much. So this is, I'm just making the last final session, and please try to be attentive. You might be tired by the since morning. You have the slide changer? You have the slide changer? Okay. Is the pointer as well? It doesn't have pointer? Desert is not there. Okay. Directed that side? Yes. Thank you. So this is what we all know. We are all aware that education and health are the two most important factors. We are all aware about it. But we are focusing on the health sector today. Health and education are quite closely interlinked because they both have impact on each other. But health itself is such a vast topic. So combining the two, probably we'll keep discussing of days together. And even today also what I'm going to say is very big subject on the which to be spoken about. But I'll try to rush through and make it as short and crispy as possible. Please bear. So health in our country is the responsibility of the state as enshrined in the constitution. So the state is responsible for that. Still, despite that, almost 75 to 80% of health expenditure in our country is still made out of pocket. 75 years, we have been wanting that the state's responsibility to state public hospital should be there to cater to the needs at least of the poor. But there also we are not able to meet till now. It's not that they were not aware. Various committees were formed to suggest how to strengthen the health system, how to establish. Since 1943, the Bohr committee was established in 1943 before independence. They submitted the report in 1946 and this known by this, that's the first committee. Then you have Mudaliar committee, Mukherjee committee twice. Then Jangalwala committee, Kartar Singh committee, Srivastava committee and Bajaj committee in 1986. So many committees, they made some, as what happens, anything happens, you make a committee, submit the report and dump it. That's what is happening. So whatever changes, the positive changes come, they come off their own by the system. Probably the reports of the committee or the recommendations were never been adopted. But still, they made certain recommendations, we achieved some of those targets, but I feel those targets achievement was more because of people's own effort and their own awareness because of so many other things in the system. So this is what from the Bajaj committee, we had a lot of noise, health for all by 2018. We all must have heard, many of us, I think, youngster you may not be remembering, but some older person might be remembering. Lot of noise in the whole world, including India. We were the signatory to that Alma-Ata was the place in the Russia. So they were, but actually nothing happened. We had some target, we projected that, okay, infant mortality will come down from 105 to 60 and we achieved to some extent. This last figure is 100%, not 11%. So this is a misprint in the report and report is available on the website of the Health Ministries in PDF form. I could edit it. This is also a busy slide, but just wanted to give you some impression that in Bajaj committee, they made recommendation that whatever manpower we have today, what we shall need by 2000, what we are producing, how much is going to be the shortfall or extra, everywhere the gap is there. But nothing has been done to fill up the gap. So what is the purpose of that report? So, but despite this, as I am mentioning, we achieved certain parameters by improvement in that. This is the infant mortality rate taken from 1950 till 2100 projection. This is the UN population report, so United Nations, we have to rely upon it. So it was almost 190 infant mortality rate per 1,000 birth in 1950. Today it is 26.6, and by 2100 it will be expected to 5.2. But same thing if you see for Japan, is that in 1950s it was 54.6, less than almost 1/4 of us. It's today's 1.6, and by 2100 it will be 0.34. So still if we call ourselves as developed nation or developing nation to reach that level, so we also try to reach those targets. Similar crude death rate, 28.2 in 1950, 7.4 currently. And this is something which is interesting to be seen why it is going to rise again, 13.7 by 2100. This is UN projection. We'll have to go through the details what made them project this. And this is the life expectancy birth in 1950, so 35.2. In 1920, it was just 20 years. Today is 70.4. By 2100 it will be 81.9. And the same thing you see for other Japan is a 60.6 at that time in 50, 85 now, 93.7 is projected for 2100. Most of developed countries like USA or Europe, most of countries, they also have the similar kind of curve. So another thing, the effects about the healthcare facilities which we have. We must know this if we have to achieve the target what we have today, what we want to achieve, and how much time we want to achieve. Then accordingly we have to set the pace. Unless we don't do it, we'll just keep having these conclaves. We'll just keep submitting the report, and nothing will come on the ground. So this is what our bed ratio is, just 0.5 public health beds per 100,000 population. If we add the private also, it becomes 1.4. This is far less than what is the ideal rate is there. For developing countries, they are reduced to 3 to 1, now 2 also per 100 patients and population. If we take this also, we need almost 4 million beds in the country today. And what we have is not even 100,000. So just 70,000 beds. That's why you see so much waiting period in the hospitals. So healthcare facilities should be, as I say, we should be easily reachable, reliable and affordable by the masses, while delivering services as per the latest standards of medical care. It's not for namesake you are giving the bed. You have to meet those medical standards also as per the need of the patient. And that is and focus should be more on promoting preventive and therapeutic healthcare system. And many of the diseases, you have been listening since morning with the dietary changes, lifestyle changes, many of the diseases, tobacco, smoking, chewing tobacco, we are spending money and buying disease. We should stop using tobacco itself. Almost 25% of ailments in the country, which includes cancer, which includes heart disease, which includes lung disease, they will be vanished. You will be saving money, which you are spending on tobacco, plus you will be getting health also. So India has a long history of original medical system coming from Vedas. We have it. And in fact, we all remember the surgical skills. Sushruta was the Indian surgeon whose instruments have been adopted with modern surgery even today in the rhinoplasty, the plastic surgery of the nose. So many things for the even eye surgery also, they were described in the literature. They are known to the whole world. We are not giving the recognition, but the world gives it. Similarly, our Ayurveda is coming up. We were pushed back, but now hopefully we are rising up again. The first modern medicine hospital system in the country was established 1664 by East India Company in Chennai. That's now named as Rajiv Gandhi Hospital. Maybe 10 generations back he might be there, 10 plus before, but today now it has been named as Rajiv Gandhi. All the hospitals are 1664. Then from 1832 onward, more hospitals started coming up. Calcutta Medical College came, then Pondicherry came, then Osmania Medical College, Lahore Medical College, Amritsar Medical College, KG and King George in Lucknow, Lady Harding in Delhi. So they started gradually coming up, but we did not keep the pace as the growing needs of the nation. Population increasing, demographic profile was changing, so many things were changing, economic structure was changing. We did not keep pace. So as such, the gap kept on widening. So private sector hospitals, since the gap was widening, so naturally the private sector had to come and play in the role to bridge the gap. So they did come, and we had some good charitable and missionary hospital also, which initially started coming up. The corporate type hospital or commercial hospital were not initially established. They came in maybe mid-80s or something when Apollo came in Chennai at that time, and then so many after that, the Escorts in Delhi, 40s, and then it was mushrooming. But initially when the public, along with the public sector hospital, we have missionary hospital and charitable hospital. Like Gangaram Hospital was established in 1991 in Delhi, in Lahore initially, then in Delhi later on. B.L. Kapoor, Mool Chand, they were all initially started charitable hospital. Today they have, by and large, they have come in corporate type. But this is how the facilities are being met with. And in the era of advanced technology, which are essential and expensive, these hospitals generally they remain updated because they don't have that bottlenecks of so many approvals which are required. So they are able to keep up with the changing time technology much faster. But at the same time, they are often blamed for making treatment very expensive. But they also can't be blamed for that because so many legal suits are coming up which have to be protected. Then you have the high land. Today, if you want to buy a plot for land hospital in Delhi, the cost will be some 300-400 crores. Then another 300-400 crores for the equipment. How do you recover that cost? Then custom duty on medical equipment. I think government at least should waive that off through through Republic Bharat channel. You must make the recommendation. Why you want to ultimately if you're charging on the custom duty on medical equipment, who's going to bear the cost? The poor patient. And that too they are charging custom duty even the government hospital also. What is the gain? From one pocket you are putting to the other pocket, and in that process you are losing money. Because I am giving you custom duty and putting some clerical work in that. You are taking that money, you are putting some putting some clerical work to that, so ultimately you are a loser. Better not take it at all. So it's necessary, and at the same time, since the public sector hospitals, they have their own problems, and private sector hospitals, they have no competition. So that is also another reason that cost will rise. So to keep a balance in the society, it's good that we have good private hospital and we have good government hospital also. The matching standard technology should be there. It's not that people should say, oh, government hospital kuch hai nahi, to hum to private mein jayenge. They should have a choice that both are equally good technically, manpower wise, and then they should be able to make a choice, and that will keep the cost in private sector also limited to some extent. So this is what I was just mentioning. The public sector hospital beds are just 25,000 in the whole country, and 43,000 in the private sector. And this is the 2019 data. You might add another 10% of this, and total is about 70,000. And as per the recommendation of WHO, we need almost 4 million beds in the country to meet the minimum standards of medical care. So public hospital, as I mentioned, remain overcrowded, especially poor patients who are unable to afford the cost of private hospital. Besides inherent apathy, lack of motivation, leadership, all these problems are there in internal politics. So that's which, and why so? Because many times what happens in a public hospital, who is the head of institution? Somebody who is the senior most. He may be a good doctor, he may be a good human being, but he may not be a good administrator. And the person who is sitting on the top has to have the leadership qualities, has to have the motivation, he has to have some vision, some dream that where he wants to take this institution to. If that is not there, he is just needing retirement 1 year, 2 years back after he is going to retire. Either he'll just sit, I'm coolly, I'm just let me pass on some time, or the other side, okay, these 2 years, I'm the head of institution, let me grab whatever I can. So whatever purchase will be, they'll also be not ethical. So these are some of the problems. That means the government should make a policy on this, that head of any institution in a public hospital, it should be by capability, not by seniority. Ask a person to show your dream, what you want to do with this hospital. Let him make a PowerPoint presentation. Let him show how he has built his own department when he was heading the department. A person who has not been able to build his own department, how shall he build the institution? So that's a simple criteria. You are the head of department till now. You brought so much positive changes in the hospital or your department which are obvious and visible. So maybe you could be one of the contender. Not that person who has not done any work in his own department during last 10 years, 20 years. Now you are making the head of institution. So where will the institution go? So these are something vital things which the government has to think. This what is I have submitted a proposal to Government of India in 2016. They had some aims already, that yellow ones. Then these are in process, and then I suggested, okay, a whole country, because aims does have a name. You attach some level of minimal standard to all those institutions. So I said at least every state should have one AIMS. Not everybody should need to rush to Delhi, and big state even can have 2 or 3 AIMS also. This is what I'm glad that some of these are being implemented. Another thing which we have to see, now again this is an AIMS campus picture. How we need to change with the changing time. Initially when AIMS was made in some in late 50s, that time AIMS was probably very far away from the main city. Naturally it was, and transport was also not there. So you had, it was, I agree that you have made it, only this part is the hospital which I have covered. Behind all yellow area is the residential area. Today, AIMS has become part of the city, overcrowded. And these days with the HRA being paid to the staff, it's good that they buy their house, use their HRA as EMI and own the house. So they can easily reduce this residential area and expand the hospital area, so that what waiting area of 2 years is there, it is definitely brought down. You can easily add another 5,000 beds. Is needed because the crowd is there, is needed. So this is something which we need to keep thinking and keep remodeling. Health sector is always, these are again with the passage of time, we have to start many new courses. With the technology is changing, we have to start many new courses. Public health, like UK have it. You have one family physician who coordinates with all the specialists. You can't take a appointment with the specialist every other day, but you keep meeting your family physician and he'll coordinate. It becomes at least there is somebody who is in charge of your entire body. Here, if you go to ENT specialist, he'll only see your ear. You go to gynecology, he'll only see the gynae part. You go to eye specialist, eye part, so he's not concerned with other things. So if there should be somebody who's overall in charge of your entire body, and then he can coordinate with other specialists to give you a consolidated advice, so there is no duplication of the treatment. So this is a few of the courses which need to introduce in our medical curriculum, especially at the postgraduate level, so that we are able to provide a comprehensive, holistic approach to the patient. Now, some policies the government has made with good intention. Intention may be good, but outcome is not good. One of those examples I'll tell you. In many states, especially in Maharashtra, I think they are still continuing. After MBBS and MD, the person has to complete 2 years bond. They have to serve in a village. Now, a young medical professional who has just passed out, it doesn't have a clinical practical experience. With today's training in medical college, they are unable to diagnose or do anything without the investigations. During our times, we had a lot of clinical exposure during our training period itself. We used to have rounds till 7 p.m., 8 p.m. in the night. Today, there is nobody in the hospital teaching students after 5 years. So he doesn't have that experience. Without investing, he will not be able to do it. He is young, 23, 24, he is probably going to get married, or he is already married, he has children, his children are somewhere and he wants to put them to the school, he'll go to rush to the cities. So although on papers he is posted in a village, but he is not there. And then because of his young age, he is not able to develop that kind of rapport or develop that kind of respect from the village people. So in lieu of that, it's better that the doctor, a clinician who is retiring or is retired, give him the possibility to go to your village or go to your hometown, serve over there for 2 years, 3 years, 5 years. He is experienced enough, he is aged also, he will be able to get respect. With experience, he will be able to give the initial first aid treatment without an investigation also. And at the same time, this young boy who you had put him over there, he can give, because he has to study further. So he is busy, he is focused over there, not in the village. So we have to change this policy. Government wanted to give a service to a rural area, but this route was not good. So that is better we encourage the retiring clinician for that. As of now, we have 703 medical colleges, as per the data in the NMC website, but we are still short because our target is 1 medical college per 1 million people. So that means we need at least 1400. So we are still 50% short. That's also a saving grace that during last 5-6 years, we have added about 300 medical colleges. Otherwise, the picture was much worse. So with this, we are able to produce almost 1 lakh plus doctors every year. So the shortfall of the doctors in the country at the moment is about 5 lakhs. So 1 lakh every year added, plus some retiring. So maybe in another 4 or 5 years, we can expect that we might be able to meet the doctor-patient requirement or ratio which is recommended as per WHO to some extent. But another problem is out of these 703, 263 are private medical college, which probably Dr. Claire was also mentioning in the morning. Now, there, the doctor is going for studying, he is paying some capitation fee of 2 crores, 3 crores. MD radiodiagnosis 2 crores, MD radiotherapy 2 crores. So a person who is paying fees of 2 crores, 3 crores, can you expect him to do ethical practice when he comes in the real life? He has to recover that money. So what we should do, we should expand more of government medical college where doctors are produced, and they let these doctors serve wherever. Initially, what experience they can get in government hospital, probably in private they will not be able to get that kind of experience, because the number of patients we see a day, they probably will not see in a month also, and a variety of cases. So it's good that private sector, instead of taking fresh recruits who is not experienced and learns unethical ways in the beginning itself, he gains experience in government hospital, gets mature enough, and then probably can shift to private if he wants to. It depends on his choice. But a person who is spending 2 crores, 3 crores for getting admission, you can't expect him to remain ethical. He has to take a recovery of his money. So this was just mentioning, the target by 2000 never achieved. Another show you in 2010 in UNO, there was a special session on non-communicable disease management. India was on a signatory, September 2010. And there were certain targets for accepted by everybody to be achieved by 2020. None has been achieved. So what's the purpose? But fortunately, now the things, of course, I hope you all realize things are changing. That for TB, the target is 2030, but we hope we will be able to achieve it by 2025, before time. Similarly, advanced preventive action, Biparjoy cyclone, managed so effectively. They took advanced action, minimal damage. At least life was not harmed. Physical damage couldn't have, because nature's flurry was so fast. Then Odisha train accident, how effective it was managed. Within 24 hours, all the casualties were removed. Within 48 to 72 hours, the track were also established, directly under the supervision of. So that means this government means business, they want to deliver. But the health sector is very complex, because you have a variety, right from the most illiterate sweeper in the hospital to the most qualified doctor in the hospital, you have to deal with all. And the patient also, you have from all the spectrum. You have to deal with the most technically advanced equipment. The manpower, like I am telling you, the technician which I was mentioning, the technical requirement of a technician some 30 years back was hardly anything. But today you want a technician which has to be highly qualified to handle so many sophisticated equipment. They are expensive and they are sophisticated. Unless he is not well qualified and trained in that, he will not be able to do that. He will damage the machine. And we want him to be better qualified, pay him also. If you throw peanuts, and you will attract monkeys. So that kind of change in government mind is still not coming, but it is required. So this is what our convictions today. In fact, I like this statement which is said, we challenge the challenge also. हम चुनौती को भी चुनौती देते हैं. This is it. And then also he said कि हम पत्थर पे लिखते हैं, मक्खन पे नहीं लिखते. We write on the stone, not on the butter. And then जब नियत साफ हो, प्रयासों में ईमानदारी हो, तो फिर कोई भी लक्ष्य कठिन नहीं रहता. If that is the thought process, I think nothing is, it's better of time chance, because there is so much of gap of so many years. Plus, people are used to doing something hanky-panky, not in an honest, dedicated way. No feeling, no nationalistic feeling in the mind of people. Anything, just grab it. You're surprised. A couple of days back in the TV also there in Gurgaon, on the roadside, for decoration they have placed some flower pots. And family from good background, they came with the car and picked up the flower pots from the roadside. That kind of mentality we have to change. It will take time, but it will change. So take some points for something. I just for this part, for cancer I come later. We must set a target that we want to achieve this by this date. It's not possible over time. You have to take 10 years, 15 years, time has to be taken. But see that after 10 years, after 15 years, how much is going to be population? What kind of disease spectrum do I expect at that time? What is my assets today? What assets I need at that time in terms of equipment, in terms of manpower? How much gap is there? And how to bridge that gap, I have to set the tone accordingly. So this kind of roadmap, unless we don't make it, we'll all keep making report every time, but they will not be implemented. But so there has to be a time, at least for this present government, he said, in fact he also said, कि हम जिसका फाउंडेशन स्टोन रखते हैं, उसका उद्घाटन भी करते हैं. So if that is attitude, I think we should be able to do it. So addition of new public hospitals, and because I said almost 50% that should be private, 50% public, but public hospitals should be equally equipped and well managed. That is important. So this is what I specifically about the cancer. I am being cancer specialist. I was asked to speak on that. I speak on that. So this is what the patient's load we have. This is the old figure. In 2016, the ICMR came with the data of 1.4 million, and today probably we have more than 1.5 million new cancer cases per year in our country. Prevalence is almost 4 million. That is almost 40 million cases at any given point of time, including new and old, some from spillover from previous year. But every year we add about 1.5 million new cancer cases to the country, which is a big number. USA also has the same number of patients every year. US population is 1/4 of us. Number of cases are same because their incidence is much high. Now, why our incidence rate is low? That is still a matter of debate. Either we are missing the cases or we are actually low. Do not know. These are some of the factors I said, and these factors are those which, if we give attention, almost 50% of cancer will be eliminated in the country. Tobacco is a useless product, but you keep getting from in our country, the incidence of tobacco smokers is rising still. In West, it has started declining in males. In females, it is rising still. In our country, both boys and girls is rising still, and you are paying it and buying disease. So these alcohol, deep fried salted fish, that kind of these are some of the predisposing factors which can be easily avoided. This is a figure which I like you to focus upon. Different countries in the world, top is United States of America. This is the upper line, that is the incidence rate, red is the death rate. So you see that difference in how the incidence line is very long, death rate is relatively smaller. If you come to the lower bottom, you see both these lines are almost the same. You see India comes in WHO South Asia region. So almost the red blue lines are almost the same. That means whatever cases we are diagnosing also, first of all the incidence rate is very low. Why it is low, we do not know. Whether we are missing the cases or we are actually low. But even if we accept this data, but even in this data, the red line is almost same as that of the other line, incidence line. So, and you see the red line is almost in all, they have so much of incidence, its red line is all the same as in. That means they are curing more patients, we are losing more patients. Why? That also see. And same thing is projected in this left side chart is with high human development index countries and low and medium human index countries. Now you see the blue line is long, but red line is relatively shorter, except in the, you see in the top, red line also long, that is lung cancer. Lung cancer is bad anywhere in the world at the moment. So lung cancer, you lose lot number of people. Therefore you see blue and red lines are nearly the same. But you see in breast cancer, in the high HDI case, breast cancer, blue line is very long, red is very short. But in the low HDI human development index cases, a red line is longer than the other cases, while the blue line is much shorter than them. That means we are losing more cases. Why we are losing more cases? Is it awareness, lack of facilities? Late stage presentation, why? So this is something we have to focus upon when we are trying to improve the facilities. These are some of the errors which are mentioning why how the things have changed and the results are changing between 50s, 50 to 70, and after 70s the results are improving because of so many factors. India is still not taking the full advantage, but definitely we are much better than what we were some 20 years before. We are much better today, but we have to do much more. This is again trying to show you that cancer incidence starts rising certainly after 35 years of age. In females little earlier and males after 35 years. Before that is there, but less. So after 35-40 years we should be very careful and at least start adopting a healthy lifestyle. This is what just data that how many cases we have today, 1.2 million, and this is about 2011. By 2030 we will have 2.5 million, double. In the world, they'll increase from 15 to 20 million, but in our country, they are going to be double. And another problem which comes is the developed countries, they have 95% of world economic resources, but their number of cases, cancer cases, just 1/3. And developing countries, just 5%, meager 5% of economic resources, but 2/3 of cancer cases. So that means we have to be very judicious when we are planning the treatment also, that it should be affordable by the system, by the government also, and by the patient also. And this was one of the main factors because of which results in our country are poor. If you see this slide, in developed countries, 80% patients they come in stage 1 and 2, where results are more than 80% cure rate. And stage 3, 4 patients are less than 20%. While in developing countries, 80% patients they come in stage 3 and 4, only 20% stage 1 and 2. So as long as 80% patients are there, so stage per stage I can say, stage per stage our cure rates almost are as good or bad as what you have in developed countries. Stage 1 they can also cure 90%, we can also cure 90%. Stage 2 they also cure 70%, we also cure 70%. Stage 3 they also cure 40%, we also cure about 40%. Stage 4 they also cure less than 10%, we also cure less than 10%. But the difference comes, their 80% are stage 1 and 2, or 80% are stage 3 and 4. So average they save almost 70% patient, and average we say there's 30% patient if we take all groups together. So one of the most important thing which is required in the field of cancer is we must plan early diagnosis of patient. Where a prevention screening is possible, that should be done, but early diagnosis must anywhere in the world, despite that technology whatever you may have. So that is the first take-home point. This again on the cancer field I am just trying to show the shortfall, how we are there. This is in the first column that I have compared the equipment, technology, manpower, everything. You see the first column, this is existing facility, present need, blue column is the present shortfall. Whatever we are producing, if you see that by year 2030, the shortfall is increasing, minus figure is increasing. So that means we have to take corrective actions to increase the establishment of facilities in that manner that we are able to, you may shift the target to 2035, I don't mind. But whatever target you set, you must take steps to achieve that also. This was what I was mentioning that in 2010 when UNO session was there, special session on non-communicable diseases. This was a 11-point charter which was agreed by all the countries including by India. Nothing has been achieved in this. So this is something, as a chief editor of one of the journal, so I wrote that editorial in 1998, what the world is talking today in cancer treatment, that AI and all those genetic diseases and immunological markers. I had written this in 1998 that this is going to be the line of cancer management and we should start doing it. But since 25 years, nothing much has been done in the country. These are all these sectors which I am mentioning, but red line which I mentioned, the bottom is prevention and early diagnosis of cancer still remains the best promise, which all of you want to remember this always. Wherever you are in your families, in your near and dears, always never neglect anything which is suspicious. It may not be cancer, I am not trying to scare anybody, but get it excluded. So again, continue the same editorial of mine, written in 1998, where I was projecting that this is how to cancer is going to get managed. Because cancer is a disease which you can't cure by just chasing it. You have to take it head on, catch from the horns. If you keep chasing it, it will keep getting smarter. So you have to anticipate how the disease is going to progress. Today with AI and with all genetic engineering and all, we can to a large extent predict how this cancer is going to behave in that given patient. In every patient is going to be different. Because in human body 2 plus 2 is never 4. It may be 4.1 somewhere, 3.9 somewhere. So every patient is an individual patient, we have to manage accordingly. And genetic sequencing is giving us a lot of help with that. So taking advantage of that, we should be able to make tailor-made arrangement for every patient. So these are important take-home points on the cancer. I just 50% of cancer I said, they are preventable. 50% we can cure early, we diagnose early. If I can diagnose early in stage 1 and 2, 90% patient can be cured. So this is in our hand. No special technology required in this. In early stage patient, treatment is simpler, results are much more rewarding. So that much, this is in our hand, this is nobody to blame. Several advancements have been made, several lab techniques have been made, but prevention and early diagnosis still remain the key to success. Patient in our country reporting late stages I mentioned, need more comprehensive cancer care hospitals. We just have 500, need 700 now, and by 2030 we'll be needing about 1500 hospitals. So we have to increase the pace of establishing more hospitals. We are just setting up 10, 12 new hospitals come up every year. We need to increase at least 30, 40 per year. Plus, request the government to at least waive off custom duties on these equipments which are used for patients, and waive off custom duty on many of the drugs, cancer drugs. Yes, government has done a lot of good work in many of the drugs these days, but still many newer drugs which are coming. What happens if pharma company develops a new molecule, cost of single dose is 2 lakhs, 3 lakhs, one dose, and if you are to patient has to take 6, 7, 8 doses, the cost will go to some 20 lakhs. Because it is patented, nobody is allowed to manufacture. But then whom they are recovering the cost from? From the patient. I simply tell them the cost of your manufacturing might be just 5,000, 10,000 rupees. Rest 1,90,000 which are added on to it is more for your promotion and your recovery of the investment which you have made in developing this molecule. So it's better that reduce the cost of the drug to 20,000. If 2 lakhs, one person is able to buy, in 20,000, 1,000 patients will be able to buy. And you see the economic logistics, probably you will be saving much more money over here. And still if you have fall short of money, we should create a corpus fund at the global level. And anybody who is spending money in developing a molecule, if he has come in the market and wants to get the cost recovered, then that corpus fund should be able to reimburse the cost to them. Ultimately, at least the patient should not be paying those costs. For your research is important, R&D is important. Without money, nothing will come. You do it, but don't recover the cost from the poor patient. Recover it from somebody else. There are so many philanthropists available in the world. They have millions. If somebody is willing to spend 1 billion rupees to defeat Modi in our country, he can very well give this money for this kind of social work, which will give him better rewards. So this is I think Deepti Sajdeva is there. She's not. So this is government hospital. This is government hospital. You are telling government hospital खराब होते हैं, अच्छे नहीं होते. And this government hospital which he made, I was the founder director for this. See the crowd. This is a dedicated cancer hospital. They are all poor patients. We used to say 1,500 patients per day. And same day blood tests were done free of cost. All drugs free of cost. All equipment functioning round the clock. This, if you wish, is possible. This is all government hospital. And see the crowd. And they are all poor patients. I've just see this crowd. Just, and they all get free treatment. Same day, everything. Not even coming for the second day. The World Cancer Day 4th February we celebrated. The HPV vaccine. We were the first one in Delhi state to start this vaccine in the country. On 7th November 2016, 7th November is the birthday of Marie Curie, who discovered radium. And radium is used in a large extent, not radium today. We have radium substitutes now, but initially first time she used radium in 1898. So in her memory we started on 7th November 2016. This is Kiran Majumdar Shah, the Baikan lady. She had visited a hospital. This is a pediatric wing. This is pediatric wing. This is general ward. The government hospital, you can see this. These are chemotherapy patients are getting chemotherapy, free chemotherapy, free drugs, everything free. And we used to give almost 175 patient chemotherapy every day, starting at 7 a.m. in the morning, many times going up to almost 2 a.m. in the night. The OPD crowd just showed you that OPD we used to start at 7 a.m. in the morning, and it would go uninterrupted till almost 7, 8 p.m. till the last patient has been seen. And even at that time, patient's blood test record will be done, and within 1 hour he will get the report also. So it's possible to do it. In AIMS, I wonder that AIMS is such a big organization, but that report which the patient brings from a lab which is not there, but report is available. Yusuf Sarai. There are many labs which are there on the papers. Patient go and get the report, and professor of AIMS is stating on the basis of those reports. So this is how we used to give food to the patient. This is on Independence Day or the 26th Republic Day or Independence Day. This is how we used to give a special kind of thing. Otherwise, meal was always good, but on special national days, with tricolor rice, tricolor chapati. There's a patient waiting. One of the machine for addition. And we had the best operation theatre with robotic surgery also. And free robotic surgery for the patient. This, and we, within 6 years, we could tie up with the biggest cancer hospital of the world, MD Anderson Cancer Center, Houston, Texas. We were established in 2006 and 2013, 7 years almost. We were the second such hospital after Tata to have signed up an MOU with them for collaboration. Tata, thank you so much for listening patiently. Anybody had the guts to ask something?
Any questions?
No, they all must be fed up since morning.
Not at all, not at all. You've been very encouraging. We have a last round if there is any question that we'd like to ask. Any comments? Grover, Mr. Grover, thank you so much, doctor.
Thank you so much.
My apologies. All right, so before we conclude today's show and conclave, let us quickly have a look at this audio visual by Jagat Pharma.